Hi, welcome. I'm Sue Dottie, a clinical program specialist with AvaSure, and I have with me today Lisa Crochet from Northwestern Marianjoy Rehabilitation in Illinois. And I also have with me Oliva Rodriguez. She's a patient care technician from the same location. Unfortunately, Mary Carlson from Mercy Health Muskegon was unable to join at the last minute due to some critical staffing needs at their hospital. This session is how monitor staff help improve nurse productivity. You may enter your questions in the Q&A box, and we'll get to those towards the end of the presentation. So, welcome again. I'm very excited about this. So we'll start. Lisa, can you tell us a little bit about your role in your Telecenter program?
Sure. I'm the nurse manager over at Marianjoy Rehab Hospital. For those of you who are not familiar with Marianjoy, we are part of Northwestern Medicine, and we are a freestanding acute care rehabilitation hospital and about 124 beds. And we have been utilizing the AvaSure telemonitor system for 3 years now. So since 2018.
Very nice. So as the leader of a Telecenter program, what are some common challenges that you face?
Well, right now for Marianjoy, we do monitor 16 patients, and that typically is our norm census on the camera system. And we do have one tech monitoring 16. I know that tends to be unheard of, but we were used to monitoring a high volume. And so I find that my techs get a little bit, I don't know, restless or feeling uneasy when we do go down in census. It's kind of odd. But I think the biggest challenge that we have right now in our setting is that we have such acuity with patients coming in for rehabilitation that we always have a wait list, it seems like. So right now, that's probably one of our biggest challenges is prioritizing and vetting through that wait list to see who can come off the camera and who should be the next one on.
And Oliva, as a patient care technician, she mentioned you guys are monitoring up to 16 patients. What's your biggest challenge that you face? Oh, did we lose her?
Did we lose her audio?
I think we may have lost her. Okay, we'll keep going. All right, how do you handle organization cultures that embrace or resist video patient monitoring? Have you run into that, especially maybe towards the beginning?
In the beginning, yes, I think it was difficult for some nursing teams to buy in and to understand how this was going to actually be helpful for them and how we were partnering and what did this look like. So I found that in the beginning, when I had some resistance or we were slow in receiving orders for CVM, one of the things that helped was for the team to, two things. One, for manager to round on the nursing units, look over the new admissions, talk to the staff. So go directly to the staff and have conversations about their patients that are listed as risk for fall, and how if CVM would be a tool that they could utilize to help, prevent falls with injury or falls, period. The other item that we captured in the beginning, which I think was instrumental to the acceptance of it, is that, we always have that crossover time of a half hour when people are handing off to the next shift. And the CVM team, they do not have to have like that whole half hour, right? Because it's pretty much giving a report, and it can be pretty streamlined. When they had that extra time, and Oliva can speak to this if we get her back on audio.
I just sent a message to see if we can't find Oliva again.
When Oliva started out, because she was there in the infancy of our program, she would go out onto the nursing unit because our office, our CVM tech office, is right there off of our stroke program unit. And so she would go out there and she would just lend a helping hand. Is there a patient that needs to get up? Is there a patient that needed a one-to-one feed? And so she would sit. And so she would kind of communicate and work within the team. And so the team could then, see her as a instrument to really shine through teamwork and then really be able to make those connections. She was no longer the unknown face, just a voice, right? So she was able to connect. Hello, Aliva.
Yes, welcome back. We lost you for a minute, but welcome back.
Yes.
So one of the questions, oh, go ahead.
Go ahead. No, go ahead, Sue, if you want to. Sorry.
No, go right ahead.
Aliva, I was just talking about in the beginning when we first started out and some of the challenges, when staff was trying to understand how the program works for them. Do we order the, CVM for the patients? And what were some of the things that we did as a team to try and make a connection with our nursing teams on the different units? And one of the things I spoke of is how before you left for your shift, you were able to go out onto the nursing units and spend a little bit of time being an extra pair of hands and just helping out, and how you kind of made that connection, especially with that One East team from stroke program.
Yes, I think that really helped out and helped build connections. They knew who they were speaking to on the phone, because prior to that, they would just speak to someone on the phone. They weren't sure who it was. They didn't really know what my personality was like. I didn't really know much of them either. So I think going around and talking to all the staff members on the floor was really helpful with that. Recently, to help kind of rebuild or build on top of that, we've been having open houses for CVM, or we've been calling them an open house, where staff members, again, because we've had more team members join since I've started 3 years ago. So now we have newer people come in. They kind of get to a little tour around our office. They get to sit down for 10, 15 minutes. They get to see my work. They get to see the patients as well on our cameras. And I think that's also helped a lot with communication with staff members on the floor and with us in the office.
And I would think that it's also helped with the understanding of your role and a better understanding of what you're doing with their patients, and building that confidence that you are watching their patients, just kind of seeing the other side of it. So one of the questions I asked, but you had disappeared briefly on us, was what are, I had asked Lisa about like the common challenges that you face. And so my question to you was, as a patient care technician, what's one of the biggest challenges you faced?
I think that was one of our greatest challenges, was communication with staff members on the floor. They weren't really sure of what my role consisted of and what it was that I was doing. And I think there was a little bit of nervousness around that. But once they did get to come around the office and kind of speak to us, get to know more of our members in the CVM team, I think that really helped smooth out a lot of those little insecurities.
So you touched on new staff. So my next question pertains to that. So what is your onboarding and training process for new monitoring staff members?
Well, they do get the module, the learning module. Every staff member gets a learning module, one that was provided by AvaSure. And then I go and do a half hour at the new employee orientation classroom for each class, and give a spiel, a little talk about CVM and some of those key components, which are so important, not only the nurse role, but the PCT role, because obviously during this classroom portion, I have both roles there attending. And, just those key points it's communication is key. We're there to partner with you. I talk about some examples of patients that, with the team working back and forth, behind the camera and the team on the unit, to really collaborate and tailor the needs of the patient that we are watching for them. So I gave them some really clear examples of what does that look like, that we're not there to annoy them with phone calls or stat alarms, but to understand what that process is. We're giving that patient that verbal redirection and trying to prevent something from happening. We're also probably dialing them at the same time to get someone to go in there. And the last item that we'll choose will be that stat alarm. We don't want to get alarm fatigue either. Right. So we're trying some interventions, but sometimes those patients are they're on a roll to go where they're not supposed to go. So we do have to result to that. So it's just really talking through the process as a new employee to understand. And they get so much information in new employee orientation that I know that we have to keep educating throughout,
Right.
as they're transitioning into their new roles on the nursing unit. So it's not a one and done.
Right. For your onboarding of staff, do you include any awareness or training for your ancillary staff, like your housekeepers or nutrition or the therapies that may encounter these devices
Yes,
in the
and
rooms?
Aliva works the night shift, so poor Aliva has a very small team on night, and it's typically the nursing supervisor. There is a security guard, and then the nursing staff, the nurses and the PCTs. Whereas I have the luxury on days and PMs, we have EVS, we have engineering, all the therapy teams are around. So boy, they do respond when they start hearing those automated messages being played, or us even just voicing into the room. What I had asked some of their leaders is to be invited to their team meetings and talk about the importance of that communication between their team and our monitoring techs. So I'll give an example because, in rehab, they're not staying in those rooms for that whole shift. They are being taken to and from their rooms. They're going to speech therapy, physical therapy, occupational therapy, psychology, or maybe an appointment in the clinic. So they're going to and from. When you're monitoring 16 patients, and Aliva, you could probably speak to this too, even though there's not a lot of movement of them leaving the rooms unless the nursing team is taking them out of the room. But boy, when you're monitoring and you're looking down at maybe the left-hand corner, and then someone has taken a patient out of a room on the top to go to a therapy, it's a
It's a heart attack.
Like a feeling. You don't like how it feels because, like, where'd Mr. Smith go? No matter how good you are at really keeping it, it really is just a few seconds where they can just, let's take you to therapy, and they go out of the room, and you're like, wait, where'd he go? Now we have their itineraries of the patients, so we know, but you always have to make sure. So when I did meet with the ancillary teams, I asked what's so important is that they communicate with us by phone call. We have a Vocera phone system, and there's also a phone in the room. They can call our landline just to say, I'm taking Mr. Smith to therapy. Just wanted to make sure that you captured that visual. We did have one occurrence occur a while back, and because of that, it was that moment of I call it the Swiss cheese moment, where all of our tools or steps that we use, layers of protection, those Swiss cheese slices just all lined up, and something just went through all the holes and just slipped past us. And that was something that communication was a huge piece of that. And that was during a nursing shift time change. So that's always a busy time. Our CVM techs were also reporting off to each other. And we have a very small office, right, Aliva? And when you have two CVM techs and they're reporting off, we had a third one in there for orientation in this particular instance. So that was a tight squeeze, a lot of, bodies in there. And a speech therapist was bringing a patient back that was on CVM, and put the nursing call light on for the patient because the patient had to go to the bathroom. The nurse saw the speech therapist and said, "Oh, we've got him. Don't worry about it. You can cancel the light. We'll be right in there." They were just finishing a couple of words about the patient next door. And in that time when that CVM or the speech therapist left, well, CVM thought he was still in speech therapy, did not see him come back into the room. And that patient scooted himself in the wheelchair into the bathroom, which totally takes them out of our view, and had a fall.
Oh, that's unfortunate.
That way we learned we need to capture when they're coming, whether they're leaving the room or when they're returning to the room, to make sure that capture of the camera, the person behind the camera, has got that patient. So it was a really good occurrence for us to learn from and realize that the communication is so important.
Yes, definitely very important. Break coverage. Aliva, can you speak to the break coverage for the monitor staff?
So I usually will get my 30-minute break during my shift, and then we also have bathroom breaks. So if I really have to take a little break from monitoring, I can call the supervisor, and we usually have someone there overnights who is trained to do breaks. And they're not necessarily trained in how to do everything on the AvaSure system, but they're trained to do, what you would have to do if, say, someone were getting up or anything like that, or if you would have to give them some privacy. That's usually what our break team consists of, is just one person and the supervisor.
So are your breaks, are they scheduled, and are they from which, you mentioned the staff that are coming in, are they from the floor? Where are these staff coming from that are covering these breaks?
They are coming in from the floor, so it's usually a PCT or what we call our PCT2s that are secretaries as well in the units. For me, it's usually just someone who's working on the floor, PCT. But we usually just speak amongst ourselves. I'll ask, what time do you have time to give me a break? Sometimes they'll have some downtime from their duties, and they'll come over and give me my break at that time.
Very nice.
Yeah. During the day and evening times, we do have unit secretaries. We call them PCT2s. I think other facilities call them HUCs. And so primarily we schedule them to do the break coverage. It's I shouldn't say it's easier, but that's how we view it. Instead of taking a PCT directly out of that direct patient care, they will cover a half hour for a CVM break. But then they have to go on break themselves. So it actually takes them out of the direct care for an hour. So we try and utilize PCT2s. Leva doesn't have that luxury on the evening, so it will be a PCT from the unit. So trying to get creative with that. And we have to make sure that we have enough cross-trained staff on all 3 shifts to cover.
Yes, I know that's a question we get a lot, is break coverage, and how is that,
Yep.
How does that work out? You mentioned that to have, the communication piece is huge. What practices and processes specifically have you implemented to encourage that good communication?
I think within our team, we are utilizing, we don't have paper documentation anymore. We are documenting on our patients directly into the electronic health record, which was a huge step for us. I'll let Aliva speak to that too, about just that movement to our safe paper system to what we were using to now an electronic system, which meant that our eyes had to go to a PC next to us. So, but we still use a single sheet for all 3 shifts to just write down anything pertinent for our team to communicate. If there was a good catch, if there was a concern, or if there was something that we had to call the help desk for a ticket to open up, and just anything. If there's a patient that the team, the techs are spending more time having to keep the eyes on that one patient, and it's taken away from the time that we're feeling that we can monitor the other 15 patients on. So that piece of the communication between us and within our team. Again, for the nursing units, it's being invited to the unit meetings. It's rounding on the unit as much as I can when I'm present. The team that I have behind the camera, the techs, are so independent and comfortable with calling charge nurses or the assigned nurse, or calling the supervisor. They're very proactive for their patients that they are monitoring, and feel very comfortable, especially in the off shifts and the weekends, to do so. They do have the supervisor to call upon if they get a little stuck or need some help, but they're very proactive to talk and communicate with the team if they have an idea. For example, we have a gentleman that we're watching, and is very active. He's actually in an enclosure bed at night, but still extremely active even within that bed. And when he's up in the wheelchair, you know, even with us monitoring him and giving him verbal redirections, it's been busy. Is the nice word to say. And so the team was calling the nursing team and saying, you know, to add another layer, maybe a reminder belt. If the reminder belt's not working, maybe the, you know, pelvic posy, you know, the nurse's job on the unit is to do that assessment. But they're really open to hearing the feedback from the monitoring team, because we're seeing that patient 24/7 and really get to know their body language and their routines. So
That's great. That is great to hear. Speaking of these, it sounds like you have really high performing staff that kind of go above and beyond,
I've been very
which is
lucky.
great. So how do you recognize those top performers?
I think I was just blessed when they walked in the door. Aliva has been here since the beginning of our program, but honestly, you need someone that, and how do you identify this in an interview? Someone that is empathetic and compassionate, because to be able to deliver care behind a camera, I mean, how do you teach that? They have to really demonstrate that, you know, the care needs of a patient and really advocate for patients. So it's asking questions about how they've advocated, you know, in their previous roles. How comfortable are they in maybe a difficult conversation? Aliva, I'm going to let you speak to a difficult conversation in regards to perceptions, which I'll give you that reminder if you have. I know you know who I'm thinking, or what the situation that we're thinking of. Yeah. But it's really a good communication, and comfort levels with obviously the skill set of using the software, and it's you really have to be proactive for your patients and being a good advocate. And sure, there's going to be differing of opinions, you know, of. Sometimes they get calls from staff saying, why isn't my patient on yet? They're still on the wait list. They should jump the wait list. You know, why is my patient not next? And it's hard. It's hard. So we have to make phone calls and see how to prioritize and have those conversations. So very difficult.
So I'm going to circle back to a couple of things that because I have a couple of questions that fit into some topics that we were already talking about. Somebody had asked about the team meetings that the non-clinical staff attend. When we talked about the orientation and catching those ancillary staff, and that, what sort of team meetings are there that you would attend for them?
Well, the nursing teams have their own unit meetings. We have 6 units at Marianjoy, nursing units, and many times I've asked to be invited to them. If we've noticed that there is maybe some communication disruption, or was a nice way of putting it, maybe there was a situation that was identified in particular, maybe the unit was having a prolonged reaction time to stat alarms, things like that. So it's really going and being proactive of just having those conversations. You know, we talk about, I mentioned perceptions, right? Everyone owns their own perception. So a really good example that Aliva had to work through one night was a nurse that was calling the supervisor, and she was upset because she felt that CBM didn't see something, didn't alert, stat alarm, didn't communicate when her patient's legs were out of the bed. And when you break it down, the nurse, that's her perception, right? So when we had further conversations, and Aliva, you know, she was, you know, really good about identifying, well, this patient's normal behavior is, those legs are constantly in and out, right? Numerous times. And she knew that when she had to hit a stat or intervene with a phone call or give the patient more verbal reminders was when that patient started maybe scooching down further, or, you know, she's full-time, so she has seen that patient numerous nights in a row, and knows that this is kind of part of that patient's normal routine. And so she didn't feel that she was at that point yet to do that stat alarm or that phone call. Perception. right? It's her
Yeah.
own perception. But what I spoke to the nurse in regards and the supervisor, I said, oh my gosh, instead of you calling the supervisor, call and talk to Aliva. She's right there.
Right.
And have that conversation. And they did have a phone call at some point. I can't remember throughout that night. Aliva, you can refresh my memory.
It was that same night I did reach out to her and I said, I am watching your patient. I saw you coming already in the room, so I didn't feel the need to use a stat alarm. And then after I did talk to her and I did kind of reassure that I am watching her patient, I am paying attention, it kind of helped her feel a little bit more secure.
Yeah. And then what we discovered is that, it is the patient is under the nurse. It's a nurse's license. And so that was part of the conversation for us to think about too, is, oh my gosh, if it makes you feel better for us to hit that stat alarm more often, oh my gosh, we will. We'll hit it all the time for you, no problem. And that wasn't being salty or anything. It truly was just being, an aha moment, like, oh my gosh, I have to really think about the nurse's role. And maybe she's not there full time and she doesn't know that this is the patient's normal routine, or maybe she's so nervous about their fall rate on the unit maybe that it just would make her feel better. So, oh my gosh, we would tailor that and change it up, just to make sure. It's just opening that communication, right?
I was gonna say, it all boils down to that good communication.
And if I'm not mistaken, Aliva, I think that was pretty much right at the time that we were starting our open houses. We were like, you know what, we need to do an open house.
Yes, that was a little bit before the open house. I think maybe a week or two after we started doing open houses, just so that everyone can kind of see what our arrangement is on the screen and how we can view their patients.
Yeah, for them to get behind the camera. Now, obviously, we're not having them take over the camera. They're just coming and sitting with us. But to sit in the role, to be the eyes behind the camera, and what does that look like?
Right.
And just to see that many patients and the activity at night. I think some perception is that the activity at night is, it's boring. Those patients are sleeping all night long. That's not the case, right?
So you talked about the nurse huddles. Are there any team huddles for non-clinical staff that you speak to for awareness?
No, they, like I said, they've invited me to their, larger team meetings when speech therapy. I went to speech therapy, occupational therapy, and physical therapy when they have their meetings. They do have some safety huddles on the unit per se at the change of shift. And usually we get feedback if there's some concern, if there's a new admission that's coming in, they'll reach out to us, but we don't always have the luxury to be at all of those meetings. We are a very tiny team. We do have the monitoring techs that we have within our team. They are in FTE positions. And then we have, like I said, some of the registry team cross-trained to step in if someone's on vacation or if someone hurts her ankle. I'm looking at Aliva. And sadly, that was right before her shift and she was bringing in pizza for the team. So again, honing in that team relationships. And here she was doing something for the good of that relationship and stepped off a curb with some pizzas wrong. So yeah. So we're always open to any avenue of, sharing the experience behind the camera, sharing in, the role of the tech to be part of each of those nursing teams, those individual nursing teams and the department as a whole.
How are you using data to help make decisions with your program?
Well, we rely a great deal on our fall rates, our yearly, fall rates. We look at them monthly. We are also looking, we review any fall, whether it was a patient on CVM or not on CVM. We review on a weekly basis. Leadership team will review with quality and risk management and discuss about is there any insight to, the fall that has occurred? And a lot of that conversation is, part of our, when a patient has a fall at Marianjoy, we do a post-fall huddle. And so it's, either the supervisor or the manager that's there that had responded to the rapid from the fall, they will do an evaluation. And part of that evaluation, one of the questions is, is this patient on CBM? If not, that's part of the discussion on that Friday fall huddle is, could we have prevented this? Was this a patient that should have been a candidate for CBM? Or was the patient on the wait list for CBM? Because we do have quite a bit, large wait list. So we do collect, any data if they were on the wait list and had a fall. The other thing, like I had mentioned earlier, we tend to use obviously all of our cameras. So one of the pieces of data that I was collecting was how, what's our average use daily and what's our average wait list. And we were collaborating with one of our sister hospitals, the acute care hospital that's closest to us, Central DuPage Hospital, which is also part of Northwestern Medicine. They use the system too. But when I would go on the dashboard, because we're all on the same server, I kept saying, they only have 4 patients on. I'm like, oh my gosh, I just need some of those cameras. So we were able to collaborate with them to have them watch 1 to 2 of our patients remotely. So it actually expanded our ability to watch. Instead of 16 patients, now we can go up to 18 patients. And boy, it's been a blessing, definitely, to even just have those couple extra cameras. But we had a lot with that collaboration to work through before, implementing it. We had a lot to work through.
I bet.
Mm-hmm.
So I'm going to go to a few questions. We're getting some good questions from audience members. One of them is, do you use a tool explaining the inclusion criteria for the patients that you're putting on the CBM?
Okay, so we do have currently in the electronic health record, when a nurse needs to order CBM or is wondering if they should order CBM, there's a drop down to see what, what type of risk is the patient, is the patient there for stroke or BI? Is the patient impulsive? What's that fall risk score assessment that was done on admission? Are we doing Medline safety? So it's all part of that, click of a button drop screen that they can do to really understand if they should put their patient on CBM. That's part of also in new employee orientation, to really review with the nurses that are ordering it, because part of the difficulty that we had in the beginning that we saw were that nurses were like, they had a new admission and they weren't 100% sure if they should order CBM. They thought, well, let's wait until see how they do throughout the night. And I'm like, if you're on that fence, jump over the fence and order it, because we don't, it doesn't hurt us if you order it when that patient came in on admission because there was something that was making you not 100% sure that that patient would stay in bed. And if we had to discontinue it the next morning, we don't. It's an easy process to order it, and implement it. It's so easy, and it certainly doesn't bother us at all if we are moving cameras around. We kind of call it the CBM shuffle, so we are moving them around all the time. So it's just understanding for the nursing team, because they do not have to have a physician's order. They do not have to have a consent. It's really a nurse's discretion if there is something going on with that patient that they feel that they need another pair of eyes to help them keep that patient safe. And very important for the PCTs on the unit, if you're a PCT and your new admission has set that bed alarm off 3 or 4 times and you've already oriented them how to use the call light, you need to let your nurse know, because if your nurse is, maybe they're doing another new admission and they're tied up. So you need to really communicate and advocate for that patient, that there's been some impulsive activity and you've answered that bed alarm now 3 times within a short amount of time.
Perfect. So you'd mentioned that you watch 16 patients at a time.
Mhm.
So one of the questions is what types of patients? And you kind of alluded to some of that. It sounds like a lot of fall patients. Do you have other
Yeah.
use cases that other types of patients you're putting these?
Gosh, we thought going into implementing the cameras that we were just really going to focus on our fall rates, right? Reducing those falls. And what we have learned over time is that we use the cameras for so much more. Obviously, Medline securement, but many times we have patients that are have seizure activity or on medication. We had one gentleman that came in and he was on a particular medication that after the infusion time of the medicine, we had to watch for 48 hours to make sure seizure activity did not occur. So we had to put this patient on just to watch for seizure activity. Obviously, patients who we were taking post-COVID and still do post-COVID patients that have been in the acute care hospital and they're still on isolation for a certain amount of days. And so that door has to be closed. So we put them on CVM so that we can keep watch on them. For just, safety. We've zoomed in many times to count respiration counts on those patients. And actually we've actually have identified when patients are having periods of apnea because they are not, all of a sudden you're like, wait a minute, I don't see that chest rising anymore. So you're doing the respiration count and then you're letting the nurse know. I'm like, you just go do a quick pulse ox on that patient and see how they're doing when they're sleeping. We've had patients that, brain injury patients that have some agitation. And if the CVM camera, we had one instance of a patient that was put on CVM. We tried to give him verbal reminders, tried to do stat alarms, but he was so fast. And so we ended up having to do a one-to-one with him. But we kept the camera in there because then he was aggressive towards that one-to-one. So it was for staff safety is why we kept the camera in there.
Yeah.
So, things that we had patients ordered for CVM use, maybe for one thing that we discovered another thing, that we didn't even realize would happen sometimes with patients, self-medication. I was surprised, I think, after we started using CVM, how often patients, gosh, in the shaving kit, they're taking a pill bottle out and you're like, because we don't search belongings, but
Right.
we ask patients, but that doesn't always, what do the patient was just really shocked that the nurse came in after we called her to let her know that the patient was taking a pill bottle and a pill we couldn't see. But the patient could understand why they couldn't take their own Xanax at home, from home at the hospital because they do all the time.
Right.
Leva, is there anything else that you can think of that has popped up into our vision that I'm missing?
We've had a lot of patients who are NPO, and we've caught either
Yeah.
themselves or their family members trying to provide them some liquid. So
Exactly.
Right. That's another great one.
Yeah, or they're on dysphagia diets. And someone brought in a Snickers once for a patient that was on a chopped diet, soft, or beef jerky. That was another one that was caught by our team.
Mandarin, I remember there was a family member that brought in mandarins for their family member who was NPO.
Yeah.
Those
So
are some great
education
answers.
was needed,
Yep.
obviously further education to family and
Definitely. Aleva, can you speak to any documentation that you do for these patients that are in this continuous observation, constant observation? Do you document every 15 minutes? Do you have a rounding sheet you document on? Can you speak to that piece of it?
So we do not document like every hour or every 15 minutes, but we do document per occasion. So if there were an event to happen, the patient gets up to go to the bathroom, I document that. When they come back from the bathroom, I also document that. So any event that happens with the patient is documented.
So we document on demand is how we put it. Aleva's stretch, I didn't want her to document every 10 minutes the patient was asleep. So when the patient got up or a behavior change, that's when she's documenting. So I think typically what we see on days and PMs is that Typically, they're documenting more often because there's so much more going on, whether it's a therapy schedule or a patient going to the bathroom or PM shift where the patients tend to be more active because they're not, therapies are done typically. So they're in their room. So there's probably a lot more interventions going on at that time.
So you mentioned several things like the MPO status, fall risk, different things. How is that communicated? Can you explain to some people in the audience who maybe don't quite understand how this works, like the process for getting the information from the staff?
So when the nurse first orders the CVM camera and we are admitting the patient, the nurse is supposed to call the CVM tech and give them a report of what is needed. My team really utilizes the addition of the software, which I love because when I go in and do a break for someone, I'm looking at those notes because the patient may be on, maybe we're observing the patient for a fall risk, impulsivity, but I need to know, do they also have a Foley? Do they have a G tube? So those notes, that note section is huge for us. We're supposed to be, any changes with the patient, they're supposed to be giving us some mini reports during the shifts. Just to be transparent, some of the nurses don't, if they don't think there's a change in the patient, they're not checking in with us or calling us. So my techs are really good about reaching out to them just to make sure. For example, we have patients that may have had a Foley catheter removed, or they're questioning because they don't see the abdominal binder over a G tube, which is another layer to help protect them from getting at that tube so fast. We may be watching them for that tube securement, but boy, if you get a patient that's fast at pulling it and likes to has their hands underneath the sheet, sometimes that abdominal binder is important. So the techs will reach out a great deal to the nursing staff just to make sure that they do truly have all the updated information in their notes.
Perfect. How long did it take, would you think, kind of estimate for the nursing staff to trust the CVM staff and to adopt the process?
Oliva, what do you think? It could have been longer than I'm going to say, but it really seemed to, once they started ordering it onto the units and really seeing how much of a assistance it was to them, that they had another pair of eyes on those patients that were really active. If I had to throw out, so I would say maybe 2 to 3 months to really, we went from I swear we went to 2 patients to 16, like in a blink of an eye. but I'm sure the process was longer than that. It's just hard to remember back then.
I think it was around that time, like 2 to 3 months. And it also took them some time to get to know us and meet all of our team. So I think around that time.
Perfect. One last question. So the title of this session was How Monitor Staff Help Improve Nurse Productivity. Do you feel that implementing this program has helped your nurse productivity?
Oh my gosh, yes. I mean, I shouldn't say rarely, I need to knock on some wood. We do not use one-to-ones as often as we used to. In fact, I would say we go months without a one-to-one in-house, and that's a huge, a huge savings. And it allows that PCT then to stay on the unit and be part of that unit and take assignments. And with staffing, challenges, that is a huge thing, that you're not taking that staffing away to use as a one-to-one sitter. And just for the nursing teams to just know that, we are doing those checks on that patient. We are visually watching that patient. So their comfort rounding, if they need to go spend the time with another patient for whatever reason, they know that they can complete that work and not feel like they have to constantly run back and check on Mr. Smith, so to speak. So definitely gives them more time to complete their duties and tasks.
Perfect. Well, I want to thank you for participating in today's breakout session. We'll We're going to take a short break now. We look forward to seeing everybody back at 3 p.m. Eastern Time for one of our most popular panels, which is Tips and Tricks from Monitor Staff Pros. Definitely a panel you don't want to miss. So thank you again all for joining. Have a great rest of your day.
Thank you for having us.
Thank you.
Thank you. Bye.